This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2011, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on understanding sleep apnea. At the conclusion of the program, participants will be able to define apnea and hypopnea, identify the causes of obstructive sleep apnea, cite the potential cardiovascular and cerebrovascular consequences of obstructive sleep apnea, and identify the various non-surgical and surgical options for treating OSA. It is my pleasure to introduce today's speaker, Tony Stigall. Tony has been a registered respiratory therapist for over 17 years and holds a master's in business administration. Tony is both a registered respiratory therapist and a registered polysomnographic technologist. After managing the respiratory therapy department at Holmes Regional Medical Center for 2 years, Tony went on to co-found the Space Coast Sleep Disorder Center in Melbourne, Florida in 2005, where he now serves as acting president. Mr. Stigall has nothing to disclose regarding conflict of interest. Specific products may be mentioned as examples of technology. Tony, welcome to the program.
Thank you, Bill. All right. We'll get started here. Obstructive sleep apnea is a sleep disorder in which breathing is disrupted by complete or intermittent collapse or obstruction in the upper airway at the level of the pharynx, despite the effort to breathe. Obstructive sleep apnea is one of 85 classifications of sleep disorders that is listed by the International Classifications of Sleep Disorders. It is also the most common classification of sleep disorder breathing. Apnea itself can be defined as a cessation or near complete cessation of airflow, which is a 90% reduction compared to baseline on the polysomnogram, that occurs at least a minimum of 10 seconds or more. Hypopnea is defined as less than 35% reduction, less than 30% reduction in the thoracic and abdominal movement or airflow compared to baseline. Hypopneas also occur at least a minimum of 10 seconds, and they are associated with a 3 to 4% decrease in oxygenation. Now, the areas where apnea can occur, we'll start with the upper airway or the pharynx. The pharynx begins at the nose and continues through to the hypopharynx. It's divided into 3 regions consisting of the nasopharynx, the oropharynx, and the hypopharynx. Obstructions, collapse, or stenosis of the airway can originate in any of these regions, and they can also occur many times within an hour of sleep or hundreds of times during the night. Other types of sleep apnea, central sleep apnea. Central sleep apnea is where the central respiratory drive is corrupted. Here the brain fails to send the correct signals, or it fails to respond to the changing levels of oxygen and carbon dioxide in the blood, and as a result the brain just fails to send the correct signals to the respiratory muscles that control breathing. Central sleep apnea is seen in patients with systolic heart failure, patients that are exposed to high altitudes, usually greater than 15,000 feet, patients that ingest opioid drugs, or medical conditions that cause damage to the region of the brain that controls breathing, usually in the brainstem. Complex sleep apnea is another type of sleep disorder. It was originally identified by the Mayo Clinic in 2006. It's a breathing pattern that consists of obstructive sleep apnea, mixed apnea, periodic breathing, and Cheyne-Stokes breathing. We see this during titrations, CPAP titrations of obstructive sleep apnea patients, and that's where they emerge. In a retrospective study of 1,286 patients, approximately 6.5% of the patients primarily diagnosed with obstructive sleep apnea developed complex sleep apnea during the CPAP titration. Most of these cases of complex sleep apnea were found to be transitory, and resolution did occur over time. However, approximately about 1.5% of the patients in the study had persistent complex sleep apnea with long-term use of CPAP. Prevalence of obstructive sleep apnea, roughly there's about 20 million Americans that are thought to have obstructive sleep apnea. That's about 6.5% of the population, or 1 in 5 or 1 in 15 Americans. What's scary is that about 85 to 90% of those estimated to have obstructive sleep apnea are undiagnosed and untreated. Approximately 24% of men and 9% of women have obstructive sleep apnea, although excessive daytime sleepiness was not always noted in these patients. I wanted to review some relevant anatomy with you. Here in this diagram, in the nasopharynx area, areas of concern would be the pharyngeal tonsils here. Here we have the soft palate, and the palatine tonsils are here, and we've got the base of the tongue in the oral pharynx. As far as relevant anatomy goes, during the nose, the internal nasal valve, the septum, and choana are areas of special concern. A lot of snoring originates there. And the nasopharynx, the hypertrophied adenoids are the most common cause of obstructive sleep apnea in children. These slides show a control where we see a 3-year-old with a normal patent airway. And on the bottom, we see an 11-year-old male with obstructive sleep apnea. And here, in these slides where you see A, those are the adenoid tonsils. And when the child falls asleep, you can see the enlargement of the palatine and the collapse here. Typically, what's done for these patients is they remove the tonsils, tonsillectomies. Other relevant anatomy would be in the oral pharynx. Here we see areas of collapse would be from the soft palate, the tonsils, the palatal glossal and palatopharyngeal arches, and the tongue. Collapse starts initially in the retropalatal and oral pharyngeal area, and approximately 56 to 75% of the patients with obstructive sleep apnea. This slide demonstrates the retropalatal collapse during sleep. Here up top we've got a patient during wakefulness, and once they fall asleep, we see the retropalatal collapse here. Let me get my arrow here. Other relevant anatomy would be in the hypopharynx. Typically here, it's the base of the tongue that's the most influential structure in this area. This is a slide of an 18-year-old male with obstructive sleep apnea. On the left, this patient here, we see where the airway is open, and on the right, in the area of the hypopharynx, we see the collapse. Causes of obstructive sleep apnea would be enlargement of the soft tissue surrounding the airway, and this is caused by hypertrophy, inflammation, edema, and obesity. Also, decreased muscle tone of the pharynx can also cause obstructive sleep apnea, and this can be exacerbated by alcohol, drugs, or neurological problems or disorders. In addition, the aging process can cause obstructive sleep apnea. As we age, it's often accompanied by muscular and neurological loss of the muscles, of the muscle tone in the airway. In addition, abnormal craniofacial morphology can cause obstructive sleep apnea. Here, a reduction in the length of the mandible or retroposition of the hyoid bone and the maxilla, the increased tongue size, macroglossia, or elongated soft palate, or increased pharyngeal fat pads can all cause obstructive sleep apnea. Some of the symptoms of obstructive sleep apnea, snoring is the most common cause or symptom of obstructive sleep apnea. 50% of the men and 30% of women in the general population of the United States are affected by habitual snoring. However, not everybody that snores has obstructive sleep apnea. Other symptoms include nocturnal choking, gasping, witnessed apnea, excessive daytime sleepiness, which has been proven to cause increased motor vehicle accidents and work-related accidents, morning headaches due to increased CO2 levels and hypoxemia, and restless sleep. Other symptoms include obesity. Obesity, as our body mass index goes north of 30, obesity becomes a factor. Here we have a patient here where you can see the centripetal fat distribution in the neck can basically exacerbate obstructive sleep apnea. And in these patients, typically, if they're able to decrease their weight to ideal body weight, that can most certainly improve the airway size and reduce some of the obstructive sleep apnea. Individuals that have a body mass index greater than 30 are considered to be obese, and additionally, patients with large necks, particularly greater than 16 inches in women and greater than 17 inches in men, these patients have a higher occurrence of obstructive sleep apnea. Also, other symptoms would include nocturia, dry mouth, impaired thinking, attention deficit, poor memory, mood irritability, depression, anxiety, and sexual dysfunction. Some of the consequences of obstructive sleep apnea. As apneas and hypopneas occur, they lead to sleep disruptions and arousals. In addition, these apneas and hypopneas cause hypoxemia and then reoxygenation. They also cause hypercapnia and hypocapnia. As we're holding our breath, we see the hypoxia and hypercapnia. And as this occurs, let's say hundreds of times during the night, we see pulmonary vasoconstriction and surges in blood pressures. And over time, we'll see, during these apneas and hypopneas, a decrease in myocardial oxygen delivery and an increase in myocardial oxygen demand. Over time, we see an impairment in the myocardial contractility that causes diastolic dysfunction over time. Some of the potential cardiovascular and cerebrovascular consequences of obstructive sleep apnea: high blood pressure. Hypertension affects 50 million Americans, and obstructive sleep apnea has been proven to cause hypertension. Other potential consequences of obstructive sleep apnea would be heart failure, arrhythmias, coronary artery disease, stroke, neuropsychological dysfunction, and dementia. And this is basically, when this is allowed to occur and it's unchecked over time, these are the consequences. Also, metabolic dysregulation. The prevalence of obstructive sleep apnea in patients with type 2 diabetes is estimated between 18 and 36%. Up to 50% of the patients with obstructive sleep apnea also have type 2 diabetes or impaired carbohydrate metabolism. The types of sleep tests that are used to assist in diagnosing obstructive sleep apnea: the polysomnogram. The type 1 PSG is basically the golden tool that's used to diagnose obstructive sleep apnea along with the clinical evaluation. The type 1 polysomnogram is an overnight polysomnogram that's essentially it takes place in a facility like a sleep laboratory, and the technician is physically there and able to respond to testing. There are minimal requirements that include recording of the EEG, EOG, the chin, electromyocardiogram, anterior tibialis, EMG, the EKG, airflow, respiratory effort, and oxygen saturation. In the type 1 polysomnogram, body position has got to be documented, as well as trained personnel has got to be in attendance. And those are the CPT codes for the type 1 polysomnogram and CPAP. Other types of sleep tests would be the type 2, type 3, and type 4, and typically these are portable monitoring tests or home sleep tests. The type 2 could still be done in a facility, but typically type 2 tests are done in the home, as well as type 3 and 4. Type 2 devices are portable devices that measure the same channels as type 1 testing, except that a heart rate monitor can be used in place of the EKG. A minimum of 7 channels have to be used. However, the main difference is that trained personnel do not have to be in attendance during a type 2 sleep study. Type 3 devices monitor and record a minimum of 4 channels. The things they've got to record is ventilation and airflow, heart rate, or EKG, and O2 saturation. Type 4 devices only require 3 channels. Measurements may include oximetry and heart rate, and the HCPCS codes are there. Each states vary as far as how these tests are performed and what the requirements are for each test. Medicare, it varies in each state. However, in most states with Medicare, in order to bill for any sleep tests, the following must be met. The sleep center or laboratory must maintain documentation on file that they're accredited either by the American Academy of Sleep Medicine or the Joint Commission. If the Joint Commission survey in the general hospital includes a hospital-based sleep lab, additional accreditation is not needed. So if the hospital is if it resides within the hospital, the Joint Commission accreditation for the hospital would cover that sleep lab. In addition, to bill for any sleep tests, let's see, did we go forward here? Documentation must be on file with Medicare on request. The ASM or Joint Commission, that applies to any hospital or freestanding facility. Physicians' offices, these include independent diagnostic testing facilities and all other non-hospital-based facilities where sleep studies are performed. Interpretation requirements for physicians. The raw data must be reviewed for all sleep tests, and depending on the states, these requirements may vary, but typically what Medicare wants to see is that physician that interprets the sleep test to be board certified in sleep medicine, and they must be a diplomat of the American Board of Sleep Medicine or a diplomat of sleep medicine by a member board such as the American Board of Medical Specialties. Or an active staff member of an AASM or Joint Commission accredited sleep center, or a diplomat of the American Board of Family Medicine with the certificate of added qualifications in sleep medicine. This slide here shows a typical montage, and this is a snapshot of a 30-second epoch of sleep. So this is a standard montage where we see the electrooculogram, and here we have the EEG, the EMG, the EKG. Here we've got we're monitoring the legs, airflow, and the respiratory flow. This blue line shows snores, and then we've got the oxygen saturation. Now, the way that we determine the severity of obstructive sleep apnea is based off of what we call the apnea-hypopnea index. And what we do to get that, it's derived from a nocturnal polysomnogram. And here what we do is we add up the total number of apneas and hypopneas and divide it by the total sleep time. An apnea-hypopnea index less than 5 is considered normal. An apnea-hypopnea index between 5 and 15 would be considered mild. An apnea-hypopnea index between 15 and 30 is moderate, and over 30 would be considered severe. This slide shows a patient that has severe obstructive sleep apnea, or just obstructive sleep apnea during REM. Here we've got up top is the PTAF, the pressure transducer airflow, and then here is the nasal oral flow. And you can see basically there's no flow going on, but there's still effort in the respiratory belts. And then corresponding, we see the desaturation where, as a result from the obstructive sleep apnea. And these events are occurring roughly about 20 seconds. So this slide shows a 56-year-old male that's got severe obstructive sleep apnea, and with this patient we see desaturations the patient's desatting into the 40s, and it's multi-positional. Let me get my arrow out. Here we've got the patient on their right side, and then they switch over to their back on their right side again and on their back, and these represent obstructive apneas, mixed apneas, hypopneas, respiratory effort-related arousals, and snore events. And as you see, this
Tony, this is Bill. I'm sorry to interrupt you. Your pointer isn't showing up on our screen. Are you using a pointer? Oh, I see it. Now I see it. Yes, I see it.
Oh, I am. Oh, can you see it now? Oh, okay. I'm sorry. The patient here fell asleep roughly in about 5 minutes, and as soon as they fell asleep, you can start the obstructive apnea start to occur, and then you see a drop in their oxygen saturations that correspond with these apneic events. And in this patient, it didn't matter whether they were on their side or on their back; they were having apneas. This represents positional obstructive sleep apnea. Now, let's make sure my pointer's working. All right. This patient here is a 39-year-old male. BMI, the apnea-hypopnea index was 26.9. BMI was 32. Essentially, they were asleep on their back for most of the night, and you can see a lot of these apneas that are occurring, as well as hypopneas, and had a period of wakefulness here. And once they turned over on their side, that's their left side, you can see they had some REM here, but there was no events that were associated with it. So this person here had apnea that was mainly on their back, so that was positional obstructive sleep apnea. As far as the treatment for obstructive sleep apnea, we've got non-surgical options and surgical options. CPAP is the gold standard for treating obstructive sleep apnea. Studies have shown that comorbid patients with obstructive sleep apnea that receive regular sustained treatment with CPAP can reduce systolic blood pressure, heart rate, and improve left ventricular ejection fraction. In addition, diabetic patients with obstructive sleep apnea using CPAP can improve insulin sensitivity and glycemic control. Bilevel is used for, well, let me back up. Bilevel, as we all know, we've got two pressures. You've got your continuous positive airway pressure and your independent inspiratory pressure. And bilevel is effective in assisting patients that have difficulty breathing against positive airway pressure. You know, patients that are elderly with chronic obstructive pulmonary disease, or just patients that have higher CPAP pressures can benefit from bilevel. Again, regular and sustained treatment with CPAP, it's been proven to reduce systolic blood pressure, heart rate, and improve left ventricular fraction, ejection fraction. Oh, why didn't that go? I'm sorry. This slide here is a slide that shows a split night titration. And typically during the split night titrations, the patient comes in and they've got to demonstrate that they have obstructive sleep apnea before we implement continuous positive airway pressure. And I just wanted to show you the effectiveness of CPAP here in this patient here with obstructive sleep apnea.
Tony, could you use your pointer to show the, there you go. Thank you.
There it is. I was opening it. So with this patient here, it took them about 30 minutes to fall asleep. And once they fell asleep, the hypopneas quickly started to occur. They were on their back for most of the time there. This person was of average height, BMI was 32. Their apnea-hypopnea index before the CPAP was implemented was 93.5. So they mainly had a lot of hypopneas, and their oxygen saturations dipped down into the 70s. But once this patient was woken up roughly about 1:30 in the morning, and CPAP was implemented right here. And you can see that they quickly titrated this patient upwards to about 10. But once they reached target pressure, the apneas and hypopneas were essentially eliminated. This patient fell asleep and was on their right side for a little while, and then switched over on their back, and then back on the right side. But we had a REM period. But again, as I said, at target pressure, their apneas and hypopneas were eliminated, and the hypoxemia improved. Their oxygenation improved to within normal limits above 90% saturations. And the post apnea-hypopnea index was 19.4. This is a CPAP titration of a 56-year-old male. The apnea-hypopnea index here was 7.6 overall, and they were titrated to 22. And once they reached, let me get my pointer out here, bear with me here. Titration started at 5, and you can see that they were having events, and then as these events were occurring, the pressure was increased. What's neat to note here is that once you see these hypopneas, the patient flipped over on their back first and then started having hypopneas, and then you see a decrease in oxygenation as well as an increase in heart rate during these events, and the pressure was increased to correspond with it. However, once target pressures were reached, we see an elimination of the apneas and hypopneas, and then the elimination of the hypoxemia as well. Not everybody can tolerate CPAP. However, there are some things that we can do to make their experience on CPAP tolerable. Number one, don't discount the interface. You know, today there are so many different interfaces that are available in the market. If a patient doesn't like the interface, if it leaks, if it is uncomfortable and it bothers them, chances are they're just not going to use it. So that is probably key to enhancing compliance. Also, heat and humidity. is another thing that can help with compliance. Exhalation pressure relief, such as C-Flex or exhalation pressure relief. And basically what this does is when you're breathing against continuous positive airway pressure, at the end of inhalation, it has the ability to reduce the CPAP, so it makes it easier to exhale. Also, following up with a sleep specialist within 31 to 90 days can also prove useful if there are some changes that need to be made in the pressure. The physician can make those changes. And then also replacing the disposable supplies on a regular basis, because typically what happens is the inserts or the cushions are made out of silicone, and over time what happens is the oil of the skin can break that cushion down, so they need to be replaced on a regular basis. Typically Medicare, depending on what type of mask you have, they'll replace them monthly if it's a full face mask, and if you've got a nasal mask or nasal cushions, Medicare replaces them they give you 2 per month. Other surgical or other non-surgical treatments would be oral appliances. Here is a mandibular repositioning device, and basically what these devices do, it's a mouthpiece that repositions the mandible, and by doing that it increases the size of the airway. And typically they're reserved for patients that have mild to moderate obstructive sleep apnea. However, there's a important caveat. In order to use these, you've got to have sound teeth, typically 6 to 10 in both the maxilla and the mandible. If you've got problems with your teeth, if your teeth are decaying, then you definitely want to consider a different option. And also, if you've got significant gum disease around the teeth, then this wouldn't be an option. Complications of mandibular repositioning devices, they can cause your teeth to be loosened, mandibular joint pain, as well as just basically discomfort and dislodging of some of your teeth. In addition, long-term use of the mandibular repositioning devices can result in permanent tooth repositioning in as many as 20% of the patients. This is a tongue repositioning device, and basically what this device does is it pulls the tongue forward and it prevents the collapse of the tongue from occurring. And again, these devices are effective in patients that have mild to moderate obstructive sleep apnea. Another option would be weight loss. And as we saw the slide before that showed the obese patient there, when you gain weight, typically once your body mass index starts going above 30, obesity can be a factor. As we gain weight, we gain weight in the obvious places like our belly and our thighs, but also we start to gain weight in our face, in our neck, and as we do gain weight there in those areas, that fatty tissue deposition in the airway can increase the size of our airway and exacerbate obstructive sleep apnea. So once you lose weight and you get down to ideal body weight, it can reduce some of the obstructive sleep apnea. However, it may not eliminate it, but it can make it better. Positional therapy, typically when we lay supine, gravity will pull that soft tissue into the airway, so laying on your sides or sleeping with the head of the bed elevated by 30 degrees can relieve some of the obstructive sleep apnea. Also, abstaining from cigarettes, alcohol, and central nervous system depressants can also reduce apnea severity. Going into surgical treatment, examination by an otolaryngologist can determine if surgery would be an option for increasing the upper airway and tone of the muscles, tone of the tissues. Some of the surgical treatments, tracheotomy, believe it or not, that was the original treatment used for patients that had severe obstructive sleep apnea in the 1970s. Nasal reconstruction, tonsillectomy, or adenoidectomy, and those are typically reserved for children, also tongue reduction surgery. Radiofrequency tissue reduction is a procedure that is being performed today. Sometimes it can be done on an outpatient basis in a physician's office. During this procedure, it's a surgical procedure that shrinks the excessive soft tissue in the upper airway, in the base of the tongue, the soft palate, and the nasal tissues like the turbinate. Here, basically what it is, it's an ablation where the targeted tissues are localized within a 60 to 90 degree Celsius range. Another more common procedure that's done by the ENT is the uvulovalvulopharyngeoplasty, or the UP3. Basically, what they do is they can remove part of the soft palate, the uvula, tonsils, and adenoids. There are complications that are associated with it. Basically, over time, they can have scar tissue that can develop, and it can make the airway smaller than what it was prior to the UP3, and it's also extremely painful. The time that it takes to heal could be anywhere from 11 days to 2 weeks. And the downside is that the UP3 has approximately about a 40% efficacy rate. The genioglossus advancement. This procedure is usually used in conjunction with other procedures, and basically here what they do is they pull the tongue forward, and by doing that, the base of the tongue, pulling it forward, the base of the tongue doesn't have that collapse in the hypopharynx. Efficacy rates when this is used with the UP3 are about 50 to 75% with patients that have obstructive sleep apnea. The hyoid myotomy and suspension. Here what is done is that the hyoid and associated muscular are advanced toward the mandible, opening the obstructed airway while simultaneously advancing the base of the tongue. It's performed in conjunction with other procedures like the UP3. And the side effects of this procedure would include dysphagia. The maxillomandibular advancement. This is surgery where the top jaw of the maxilla and the bottom jaw are broken and they're moved forward. It's reserved for severe cases of obstructive sleep apnea. Here, basically, they just let me get my arrow. Okay. With this procedure, they basically cut through the maxilla and move it forward, and the same thing is done with the mandible. And it's extremely painful and only used in severe cases of obstructive sleep apnea. I would think that, another option for me, if that were me, I'd go with the tracheotomy. Other surgical options. With the UP3 and the Stanford protocol, and what they did is they combined several of these procedures that we just discussed in the 2 phases. With the UP3, phase 1 consisted of the UP3 alone, the genioglossus advancement, and the hyoid myotomy. After the patient healed, they would perform another polysomnogram. If phase 1 if it showed that they still had significant obstructive sleep apnea, after 6 months, phase 2 was implemented, and basically there they did the maxillomandibular advancement. In these patients, roughly 90% of them can expect significant improvement, and 60 to 70% of the patients that underwent the phase 1 and phase 2 of the Stanford protocol were entirely cured. In review, early diagnosis and treatment of obstructive sleep apnea can reduce cardiovascular morbidity and mortality. Patients that are suspected of sleep apnea should consult with a sleep specialist for evaluation and management. Questions?
Okay, Tony, thank you very much. That's a very sleep apnea, of course, obstructive sleep apnea is a huge problem for our society, and I think you've given us some great information here to better understand the disorder and the possible treatments that are available to address it. We had a couple questions and comments come up in our presentation today, which I will share with you right now. Hang on just a second. I'll get my phone up here. One of our participants want to know about made the observation that C-flex sounds similar to BiPAP. Can you explain the difference for us?
Sure. With bilevel, you've got two pressures. You've got an inspiratory pressure, and on top of your continuous positive airway pressure. So, what's different with C-flex is C-flex, it has the ability to determine when the end of inhalation occurs, and what it does is it just lowers the CPAP. So they both decrease the work of breathing. However, bilevel basically has separate pressure upon inhalation. What it does is it augments the breath, and it just makes it easier to breathe. C-flex, basically, what it does at the end of inhalation, it lowers that pressure by usually 1, 2, or 3. And same thing with exhalation pressure relief. When you at the end of inhalation, it lowers the CPAP pressure, and so when the patient exhales, it makes it easier for them to breathe.
Diane wants to know that during the sleep study, is the patient's sleep position changed by the sleep study technologist in order to assess the effect of different positions?
Typically, what we try to get the patients, we ask them to try to sleep on their back. However, they don't always do it, but by doing that, if they sleep on their back, sleeping supine, if let's say it's a mild case, we'll be able to see it. I know that we've had patients that had extreme daytime sleepiness, and they slept on their sides the whole night, and then an MSL or a multiple sleep latency test was ordered, and before we went on with that, we made sure that we had those patients sleep on their back, and once they slept supine, they had moderate obstructive sleep apnea. So positional therapy, you can't really, or positional sleeping, you can't really discount it, because some people, they may not have obstructive sleep apnea sleeping on their sides or with the head of the bed elevated, but once they sleep supine, obstructive sleep apnea can emerge.
Yeah. Okay,
hope I answered that question.
Lawrence raises the issue of dental and periodontal disease and its relation with sleep apnea. Can you comment on that at all? Have you worked with any oral surgeons that dealt with this patient population?
As far as periodontal disease, I would say no. We do have patients that we refer out for the oral appliances. I do know that we've seen a fair share that opted to do the oral appliances first, and then they come in complaining of the mandibular joint pain. So, then they decided to go with CPAP. But as far as the periodontal disease, I have not seen patients in that population. You had mentioned a surgical treatment of pulling the tongue forward, and what one of our participants wanted to know is, does that have any impact on the patient's speech? Honestly, I really can't answer that question. I've read about these studies, but I have not talked to anyone that's had it done. Typically most patients don't opt for that procedure, and that procedure isn't done as a standalone treatment. It's usually done in conjunction with the UP3. Faye
makes the observation that surgical options are really painful, and usually the patient can't even swallow their secretions. Is that your experience in general?
Yes. Yep. I've seen a lot of patients that initially they had a great response because they're not eating for 10 days. They're on a liquid diet for 10 days, even 2 weeks, and even after that, so they might lose 20 pounds during that process, 15 pounds, and so they feel great. But then over time, when they start gaining the weight back, those symptoms of obstructive sleep apnea can appear. And then in some patients, again, they develop scar tissue, and like I said earlier, that their original size of their airway increases, and it can be just as bad as it was before, if not worse. So, I mean, I've seen mixed results. I've seen patients that had that procedure done. It worked really well for them. But everybody that's had it says it's extremely painful, and if they had a choice to do it all over again, they wouldn't do it.
For you right there. I'm probably going to mispronounce this, but John is asking about palatial, P-A-L-A-T-I-L, implants. Do you know anything about those, or can you comment on those? He wants to know, what about these?
Is that like the implants where they're doing electrical stimulus?
And if you get, maybe John can come back in and clarify his question for us. Actually, I'm reading off my list of questions here. I'm not looking live into the chat area. Let's see. One person wants to know, what can you tell us about those valves nasal plugs?
You know, I read about them, and you know, from the studies from that paperwork, what it said was that it was okay to use in patients that had mild to severe obstructive sleep apnea. I personally don't have any experience with it, but my medical director and I discussed it, and you know, we want to start sending some of our non-compliant CPAP patients and let them try it. I do know that, you know, they come with like a 30-day supply, and obviously, you know, they break down pretty quick, so you've got to use a new pair every night.
So it is a disposable product, then, from what you're saying.
It's a disposable product, and basically what it does is that on inhalation, it's got like a kind of like a one-way valve. You know, so when on inhalation through your nose, you can breathe in, but on exhalation, it kind of has like a valve that prevents full exhalation, and so what it does is it creates PEEP. And so they say that by doing that, it can help with mild to moderate, even severe cases. But I kind of have my doubts on
I
the
must know that in the AHI equation, what is the sleep time, or is the sleep time in hours? In the AHI equation, it's in minutes. Okay.
No, it's in minutes.
And Scott wants to know, how do you tell if your child needs a study?
Well, you know, if your child has, let's say, you know, if they're snoring, or if they've got moodiness, or, you know, they can't sleep, you know, certainly you want to take them to somebody that's board certified in sleep medicine and have them do an evaluation. I know that based on some of the patients that come through here, some of the reasons why they were referred was just their inability to pay attention at school. You know, they had some of their grades were falling. They just had attention deficit problems, and their primary physician recommended a sleep study. And another thing, to get back to the original question, is that, you know, if you look in the airway, typically if they've got enlarged soft tissue in the back of the throat, you know, you can kind of base this off of like a Malampati classification. And if you just Google Malampati classification, what it does is it shows it's a tool that demonstrates airway patency. It would show like what a normal patent airway would look like, with minimal size of the tonsils and the pillars there, and the soft tissue, and it's based off of a scale of 1 to 4, and the larger the soft tissue, the more propensity that the patient would have towards obstructive sleep apnea. It was originally designed by anesthesiologists to determine the difficulty for intubating patients, but a lot of physicians now use that scale to determine if a patient may have obstructive sleep apnea.
Tony, there's a question here, about titration using the auto SV as an option for CSA and complex OSA. Is that an option?
Yes, you know, I really didn't want to get into that. I mean, because I didn't know if I'd have enough time, but the auto SV is basically the gold standard now for treating central sleep apnea and complex sleep apnea. And essentially what these devices do is they utilize servo ventilation And they're remarkable devices. What they do is essentially they have the ability to look at each breath, and they record it over a 4-minute window. There's an algorithm, and it looks at the flow of each breath, and so it can determine if the patient's having apneas and hypopneas, and it can certainly differentiate between central apneas and obstructive apneas. And what it does is it looks at a minute volume over time, and so once you get the CPAP titrated correctly and the patient starts having apneas and hypopneas, it's looking at the minute volume. And so when it sees a decrease in the minute volume, then basically the CPAP will start breathing for that patient to basically keep that minute volume within a target, within a 4-minute rolling window. It's looking at the minute volume in conjunction with a number of other factors.
Okay.
And like the Respironics makes an auto SV as well as ResMed. I believe those are the only two manufacturers that make it. But the Respironics ASV Advanced, it's got an auto CPAP titration as well as the ASV, and it makes it really nice for these titrations on these patients that have mixed apnea or complex sleep apnea and central apnea as well.
Thank you. One person wants to know why they don't make pediatric full face masks.
Typically because usually when you see these small children, what they do is they remove the tonsils and adenoids. And so, in really small children, like 5, 6-year-olds, you don't really see a whole lot of those children with CPAPs. But I do know that they are making them. You just have to look. I've talked to some of the vendors that have come through here and asked me if we do titrations on children and that they have masks for them. I know that Respironics and ResMed, they have really small masks. They don't advertise that they're for the pediatric population, but due to the size, you certainly could use them if push came to shove.
Okay. I have an interesting report here. One of our participants says he had a patient who seems to have airway obstruction during exhalation, very similar to grunting. This occurs while she's sleeping. How would you classify this, or the significance of this type of obstruction? Have you heard of anything like that?
On exhalation?
Yes. Wait. Yes. Obstruction during exhalation, similar to grunting.
No, I really can't comment on that.
Let's move on then. One person wants to know, at what age do children generally exhibit the clinical issue from obstructive sleep apnea? Or is it related to age?
It's not. I know that babies can have it, and basically the mothers would notice that the child's not breathing. But even in children that are 2, people that these children are 2 or less, if you notice that they're irritable and maybe they're snoring or enlarged soft tissue in the back of the throat. Bottom line is, if you suspect that your child has a sleep disorder, you need to take them to a board-certified sleep specialist and have them evaluated.
Okay, good advice. One person says, I've been using a machine that has the option of AFlex, which reduces pressure before inspiration comes to an end. Would this be any better than the C-Flex setting?
The AFlex, I believe, it's automatic. I really don't use that setting, although I've seen it. I just basically put everybody, based on their settings, on C-Flex of 2 or 3. And the AFlex, I believe, is like automatic, and it's where it's determined by the patient demand. So that's something that you want to talk to the DME company and then the physician to determine if that's going to be the best option for you. Okay,
Tony, I want to thank you again for a very enlightening presentation today and for answering some of these questions. And I apologize to those of you that submitted questions that we could not get to. We just had a lot of questions today and a fair amount of question time. But I'm glad you all are paying attention. I'm glad you all have questions. So, let's see. For those of you that are watching this presentation as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.